So these were a few of my thoughts when preparing for this session. First of all, with the increasing use of screening, we will have more patients presenting with early-stage rectal cancer. And in my opinion, the optimal treatment of these patients requires further study. We need to assess the role of minimal invasive surgery, of radiotherapy. Also, our population is aging, so we will also be confronted with more elderly patients with rectal cancer, and the treatment of these frail patients remains a challenge, in my opinion, and maybe a possibility is that we treat these patients with a short course of radiotherapy only and follow them and then see how they evolve. Also, for both populations mentioned in my two previous points, we should look into the role of intracavitary brachytherapy, or also into the papillon technique, as was presented by Jean-Pierre Gérard earlier during this meeting. For the more advanced patients, I think that a patient-tailored treatment is the way forward. And we've heard Abrahama explaining organ-sparing surgery, and this is an appealing approach for patients who obtain a clinical complete remission after preoperative chemoradiotherapy. But it still remains hard to predict which patients will actually obtain a clinical complete remission, and there I think there is a role for functional imaging modalities such as FDG PET-CT and functional MRI, including diffusion-weighted MRI. So when we image these patients early during preoperative chemoradiotherapy, we might be able to predict which patients can go to an organ-preserving strategy or which patients should go to TME surgery. Then we have, unfortunately, still patients that respond poorly to standard chemoradiation. And if we look at the data from big studies and from meta-analysis, we see a clear response to radiotherapy. So the higher the dose, the more likely the patient is to obtain a clinical complete response. So we should look into radiation dose escalation for the poor responders. But this is not an easy task, and so I think that there might be a role for MR linear accelerators, because with a combined machine, it is possible to image the patient during treatment and to really focus the high dose of radiation to the macroscopic tumor. Also, proton therapy, in my opinion, has a bright future because it's possible with proton therapy to reduce the dose to the healthy organs. And so, apart from sparing our normal tissues, it also offers the possibility to look into dose escalation, although there the major challenge is that the tumors move during radiotherapy, and with our BRAC peak, we have the risk of missing the tumor when it moves during the delivery of the treatment. And then for those patients that present with oligometastatic disease, we have heard about RFA and we have heard about surgery. But we should not forget that stereotactic body radiotherapy, using a few large doses per fraction, is also a valid treatment in patients with oligometastatic disease. And in my opinion, patient empowerment also becomes more important. We have seen today the numbers needed to treat in order to spare one local recurrence. These numbers are becoming larger and larger, so we should involve patients in our decision on whether to go for pre-op treatment or not. And I think decision aids can play a role here in guiding our patients through their decision. These were my few points I wanted to raise.
Thank you, Karin. Questions? How do you see us integrating with more concrete and more precisely in the near future proton therapy in rectal cancer? And in other words, should many countries or regions or centers start to invest in proton therapy, or do you think that's going to be a fashionable wave regarding rectal cancer?
If we look at what is happening in the States and what is happening in Europe, we see that more and more countries are investing in proton therapy. In the Netherlands, for instance, there is an agreement now to install 4 big proton centers. In Belgium, we also got an agreement to install 1 proton center. Proton therapy it is proven to be superior in children and also in some rare adult tumors close to the central nervous system. So this is what we call the standard indications. There is no discussion. Patients that present with such tumors should be referred for proton therapy if it's not available in the country. And then we have what we call model-based indications. So these are indications where when you compare the two treatment plans with photons and with protons, the proton plan is superior. And so these patients, if you have proton therapy available, should be referred for protons. If you ask me about rectal cancer, then I have many questions. I think for recurrent rectal cancer after previous treatment with photons, there is certainly a role for protons because it's very hard to re-irradiate them with photons. In the primary treatment of rectal cancers, the challenges, the major challenges are that we cannot see the tumor, so we have the risk of missing the tumor, and also the tumor is moving during treatment, and again with this steep Bragg peak, we have the risk that we miss the tumor during the radiotherapy delivery. So for the primary treatment, I think it should be done in studies, and then I'm afraid that we will end up with big volumes to be sure that we really hit the tumor, and then if we go for large volumes, you can question the additional benefit of protons compared to photons.
Mm-hmm. Yes, please. Thank you.
I'm a bit skeptical that MRI linear accelerator will be the best tool within the next, let's say, 12 or 24 months. I think, or I guess what you mean is adaptive radiation or radiotherapy, and this, I fully agree, might be an interesting tool within the next 1 or 2 years. Adaptive radiation means that we try to adapt our treatment volume with respect to, let's say, maybe possible tumor shrinking during treatment. But everything we heard about MRI during the last 1.5 days, and everything you can expect with or about MRI images connected to a linear accelerator, at the moment I'm sure you will never get the quality you need to really adapt treatment volume with this technique. But adaptive treatment with using other techniques is really interesting, in my opinion.
Well, I don't have an MR accelerator available in my department, but what I hear from people installing these machines is that the 1.5 Tesla MR that is in these machines is good enough, at least the T2-weighted imaging, to view the macroscopic tumor during treatment, and of course we will still need our safety margins. To visualize a tumor during treatment is not easy. With our current accelerators, if we use cone beam CT, it's hard to see the tumor, so then we have to introduce clips to be able to see the tumor during treatment and to track the tumor. But then when you introduce clips, then you also introduce artifacts. You cannot re-image the patients with MR because of the artifacts, so you have to remove the clips before re-imaging. It gets very complicated with a cone beam CT on an MR, on a simple accelerator.
In Germany, we have now the CyberKnife. Is that the same like stereotactic body radiotherapy? They apply 60 gray on 1 day on a lesion. Is that the future for a recurrence of rectal cancer? Or?
With the, I don't know about recurrent rectal cancer and CyberKnife, but what I do know is that with CyberKnife you can indeed treat oligometastatic disease. The disadvantage of a CyberKnife is that it takes quite a long time to deliver this large dose to the patient, and then you have the radiobiology aspects that the longer the overall treatment time, the more chance there is for DNA repair in the tumor, for even repopulation. So my preference would be to go for an ordinary accelerator to deliver stereotactic body radiotherapy, but I know people do it with the CyberKnife as well.
Karin, that's short. If you were to have in the next 12 months your MRI-guided machine, or you have the Varian TrueBeam, or you have Proton, would you took a patient with stage 3, 3 to 4 rectal cancer, and which machine? Given that technology is you are trained.
On the MR accelerator.
Because
I have a TrueBeam available, so I can already treat my patients with a TrueBeam. And I will have a proton machine available, but I think we need further studies before we will use protons in rectal cancer.
Okay, thank you. Let's go.